Today I'm going to talk about an approach to the patient with combined vestibular and cerebellar disorders, or central and peripheral disease. The traditional dichotomy of central versus peripheral causes of imbalance may at times be a hindrance rather than an aid to the diagnostic process. As you will all know, diagnosis of balance disorders is often challenging, with no single cause accounting for more than 5 to 10% of cases. Previously described, as well as new diseases with the combination of central and peripheral features, are increasingly recognised, and value here is in both prognostication as well as management. So when should we suspect a central component? When there are red flags on history, and these include patients not responding to management in the way that we would expect, patients whose condition worsens whilst on management, and those who develop new features over time. On examination, we're going to talk about red flags as well as detailed central signs, but just to note that the focus here is on chronic, not on acute disease. So let's talk about gait first. The classic cerebellar gait is that which is broad-based, unsteady with lateral veering. There's a reduction in speed, step length, as well as an increase in the double limb support phase. Importantly, there's external rotation at the hip joints. It's important to observe a turn, as we'll often see lateral steps on turns, and if possible, examine the patient at their preferred speed as well as a slow speed. Patients with cerebellar ataxia will often walk faster to improve their gait, and so a slow speed may bring out features of the ataxic gait. So here we see a chap walking with the classic gait, broad-based external rotation at the hips, 3 steps on the turn, and here we see a patient with a more severe gait, so broader base at the medial malleoli, very unsteady on the turn, with lateral veering. So, examination of appendicular ataxia. In the upper limbs, the finger-nose or finger-chin test, looking for signs of dysmetria, so inaccuracy or difficulty measuring the movement, and intention tremor, often misunderstood as an action tremor, but an intention tremor is specific in that it increases in amplitude as the target is approached at both the chin end of the movement and the clinician's finger. Dyssynergia, which is a decomposition of the movement. Ballistic tracking or finger chase, looking for decreased latency, speed, and dysmetria, often seen as an overshoot and an oscillation back to the target. Ramp tracking, where we see jerky and irregular movements. In the lower limbs, we look at the heel, knee, shin test. Important to take note of the approach of the heel to the patella, looking for the intention tremor, and then dysmetria on the shin slide phase. The toe finger test, the analogue of the finger nose test, but in the lower limb, and rhythmic tapping, which can be used in either the upper or lower limbs, where there is proximal weakness, which may confound the above mentioned tests. And so we have the patient tap their foot or hand against our hand, looking for variability in the inter-tap intervals. Okay, so here we see ballistic tracking with dysmetria, overshoot and oscillations. And here we see the finger nose test with a degree of intention tremor at either end. And here the test of dysdiadochokinesia, which can be abnormal in both Parkinsonian and cerebellar conditions. And here we see the heel-knee shin test with dysmetria on the shin slide phase, as well as an intention tremor as the heel approaches the patella. Visual vestibular or cerebellovestibular oculomotor abnormalities are very important here, as they cover both the peripheral and central vestibular mechanisms. VOR suppression or cancellation of the VOR is a cerebellum-mediated function and usually acts to suppress VOR so that gaze can be changed during head movement. For example, you might be walking down the street, looking at your watch and turning left at the same time. In order to avoid the VOR driving your eyes off the watch face, VOR suppression is required. VRS involves subtraction of the contribution of VOR from eye movement. Now, the study of VOR in isolation is a useful research metric, but I think it's important to remember that in day-to-day visually guided tasks, the VOR is constantly interacting with other oculomotor or visual reflexes, hence visual vestibular interactions. And this anatomically are the interactions between the vestibular apparatus and the cerebellum. The process by which, I'll just carry on, visual vestibular interactions, the visually enhanced vestibular ocular reflex or VVOR is probably the most important test here, and it is the combination of VOR and smooth pursuit with a lesser contribution of the optokinetic reflex. So VOR is the addition of VOR and vision. Vision here being principally smooth pursuit, and it functions to stabilize the image of an earth-fixed target while the subject is moving. VOR and smooth pursuit are the function of cerebellar and bilateral vestibular function, hence an abnormal or saccadic VVOR indicates the combination of cerebellar and bilateral vestibular impairment. So just to go through this again, abnormal VVOR is a combination abnormality of visual pursuit, a cerebellar function, and VOR, a vestibular function. An impaired VVOR is very easily demonstrated by turning the patient's head slowly from side to side while the patient fixates on an earth-fixed target such as a dot on the wall or the clinician's nose. And what you're looking for are compensatory eye movements which are saccadic rather than smooth. The VVOR then really is a very simple bedside test, and one that most of you are doing perhaps without realizing it prior to doing the head impulse test when you check that the patient's adequately relaxed. In the top left trace here, red is the head, black is the eyes movements. So we see that the gain is 1 as the traces overlay each other, and that there are small normal corrective saccades. If we look at the main panel, we see that the gain is less than 1, the traces do not overlie, and there are salvos of high amplitude corrective saccades with each movement of the head. Now, we don't resolve these as multiple saccades, but we see these as saccadic movements. And so here, the patient's head is getting moved side to side, and you can see that rather than smooth, the movements are broken up or saccadic, and that is an abnormal VVOR reflecting the compound abnormality of a bilateral vestibulopathy and cerebellar impairment. So what's the clinical relevance of an abnormal VVOR? Where you see an abnormal VVOR, this is indicative of patients with cerebellar ataxia and bilateral vestibular hypofunction. There are an increasing number of diagnoses other than canvas, which we'll talk about in some detail. And the term for this phenotype is cerebellar ataxia and bilateral vestibulopathy, or CAB-V, and we see this in spinocerebellar ataxias type 3 and 6. For example, Friedreich's ataxia, multiple systems atrophy of the cerebellar type, MSAC, Wernicke syndrome, idiopathic CAB-V, and in cases of combined pathology of independent etiologies, such as a patient who has had a Chiari malformation leading to cerebellar impairment, and then following decompression, gentamicin vestibulotoxicity. So 2 causes, but the resultant phenotype is that of CAB-V. Of course, in most cases, we look for a unifying single cause. Continuing this idea that the dichotomy of central versus peripheral may not always be helpful, let's look at the anatomy. So the vestibular nuclei are located in the medulla, i.e. outside the cerebellum, and hence are not named cerebellar nuclei, but are generally considered to be the anatomic equivalent of the deep cerebellar nuclei, i.e. cerebellar nuclei that went somewhat wayward during embryological development. The cerebellar nuclei and the lateral vestibular nucleus are the efferent or output pathways of the cerebellum, and the lateral vestibular nucleus does not receive vestibular root fibres, but receives cerebellar input in the form of Purkinje cell axons. Therefore, they're considered to be cerebellar rather than vestibular nucleus. So let's just go through some practice points here. A broad-based unsteady gait or an ataxic gait may be due to an impairment in either the cerebellar, vestibular, and or somatosensory symptoms. Therefore, it follows that any patient who presents with the diagnosis of isolated bilateral vestibulopathy or cerebellar ataxia or a peripheral neuropathy should be assessed for the presence of 1 or 2 of the other deficits. We are increasingly finding that patients are assessed as having a cerebellar ataxia, and the clinicians are not searching for other components of the ataxia and miss out on describing the patient's complete clinical picture, which may have a vestibulopathy and or neuropathy or neuronopathy, which would help in their diagnosis. Next point is that of cerebellar impairment. So in terms of cerebellar oculomotor abnormalities, we'll look for saccadic visual pursuit, gaze evoked or downbeat nystagmus, as well as abnormal saccades to target. we listen for cerebellar dysarthria, and as previously mentioned, we look for limb ataxia. We're not too fussed by an absence of cerebellar atrophy on MRI, as this may be absent particularly in the earlier stages of disease, and this is most likely a function of the fact that clinically we are using qualitative rather than quantitative MRI scanning. With regard to diagnosing vestibular hypofunction, I don't think I need to go through this in great detail, but the instrumented objective metrics include the video head impulse test, as well as caloric irrigation and the rotatory chair. Here we have the head impulse test. Black is the head movement, red is the head movement. The gain here is extremely low at close to 0, and what we see are salvos of corrective catch-up eye movements, which to our eyes are resolved as a single corrective movement following the head impulse test. Here you'll see a patient with canvas who I'm impulsing, and you can see that very low VOR gain is obvious by the very delayed catch-up saccades bilaterally. So with regard to clinical diagnosis of the somatosensory deficit, abnormal or absent perception of one or more of the modalities of light touch, pinprick, vibration and joint position sense. However, of all the bedside examinations, the sensory is the least reliable, and so if suspected, this is best evaluated objectively with a nerve conduction study looking for reduced or absent sensory nerve action potentials. Combined cerebellar and bilateral vestibular impairment is, as previously mentioned, best recognized by an abnormal visually enhanced VOR. Early VOR abnormalities are more easily visualized with objective metrics such as infrared video oculography or rapid video oculography. We find the rotational chair to be less sensitive. So I'll now talk a little bit about canvas, which is cerebellar ataxia with neuropathy and vestibular areflexia syndrome. This is the triad of cerebellar impairment, bilateral vestibular hypofunction, a somatosensory deficit, and a chronic neurogenic cough. Prior to the recognition of canvas, most of these patients were diagnosed with idiopathic late-onset cerebellar ataxia. It's worth noting that in our initial cohort of 100 patients, 1/3 had affected siblings, and so the suspicion of a genetic disorder was very high. So the first component is cerebellar impairment, and here we see a specific pattern of atrophy on the MRI. So looking at panel A, you see atrophy of CRUS1, the arrows pointing to the increased CSF space either side of CRUS1, whilst in the midline or vermis, the atrophy was of lobule 6, 7A and 7B. We were able to confirm this on post-mortem samples, and you'll see that panels C and D reflect the MRI findings. Under high-power microscopy in panel F, you can see the white line travelling vertically is the Purkinje cell layer, and this was the principal cell population involved in canvas. I've just put in a trace bottom left of visual pursuit, so that red is the head, which is stable, and that the eyes are the black traces with multiple high amplitude corrective saccades simulating broken up or saccadic pursuit. So the second component, the bilateral vestibulopathy, top left you can see the normal vestibular and cochlear nerve are well stained. Top right in the canvas patient you see the normal cochlear nerve, but the poorly stained atrophic vestibular nerve. However, under high power, we see on the left in the normal case there are many of the large fluffy purple cells. These are the scarpa or vestibular ganglion cells, whilst on the right you see very few of these cells, and so the underlying pathology was that of a vestibular ganglionopathy. As regards the peripheral sensory deficit, the underlying pathology here is a dorsal root ganglionopathy, and if we look at the panel on the left, the arrows point to normal dorsal root ganglia, whilst in panel B the roots are somewhat atrophic, fine and hair-like, and this represents the atrophy. If we now look at panel on the right, the middle panel shows the dorsal root ganglia with very few remaining neurons. The panel above that shows secondary demyelination in the spinal cord, while the lower panel shows electron microscopy with severe axonal loss in the peripheral nerve. But again, this is secondary to the dorsal root ganglia loss, so again a ganglionopathy. So just coming back again to the VVOR, what we're looking at here are slow sinusoidal head movements, and looking at the eye trace, we see salvos of high amplitude corrective saccades as the head is being moved side to side. After many years, we were able to delineate the genetics of canvas, which is caused by an expanded intronic pentamina, so a pentamina having 5 base pairs, and this was in the gene called RFC1, replication factor C subunit 1. It was very difficult to locate as it was intronic, and for many years the standard research tool was whole exome rather than whole genome sequencing. The discovery of a pentamina rather than a triplet repeat, which is responsible for many other inherited neurological conditions, adds an extra layer of complexity in that there are multiple variations of A's and G's, and the pathology associated with these various combinations is still being elucidated. I should mention that canvas or RFC1 related disease is recessive. And this is just an acknowledgement of all those involved in the canvas research to date. And in conclusion of the overall talk, combined cerebellar and peripheral vestibular dysfunction should be considered in any chronic, particularly progressive gait ataxia. The presence of either a bilateral vestibulopathy or cerebellar ataxia should not preclude investigation of the other or of a somatosensory deficit. And finally, the development of more precise phenotypes and the expansion of available genetic testing holds the promise of improved disease taxonomy, holds the promise of more definitive diagnosis and treatments.